Let's transition to nutritional syndromes. Why is this relevant? It's relevant again because we practice evidence-based standard of care. So in evidence-based medicine, our assessments and our intervention should translate into an improvement in quality of life and life expectancy, or a decrease in morbidity and mortality. And again, this should be guided by the 4 M's in the 4 M's framework. What matters to the patient? So our goals of care should be aligned with the patient's will and the patient's wishes. Mentation, mobility, and medication. Whatever we do in terms of assessment and intervention should impact the patient's quality of life in such a way that it should translate into an improvement in the patient's ability to perform activities of daily living and or instrumental activities of daily living. This should translate into a decrease in disability, a decrease in dependency, and an improvement in the patient's ability to function independently. Why is this relevant? It's relevant because there are age-related changes in the older adult's body. Some age-related changes include changes in the body's composition in such a way that there's a decrease in bone mass, or a decrease in lean muscle mass, a decrease in skeletal muscle mass, and a decrease in the water content of the body. This decline in the water content, or this decline in the bone mass, or this decline in fat content, it all leads to a change in bioavailability, or it affects the bioavailability, and it affects the volume of distribution of vitamins and or minerals. And this has clinical implications. And it has clinical implications in such a way that standardized nutrient requirements for younger or middle-aged adults cannot and should not be generalized to older adults, and standardized prescribing habits that are used, or standardized prescribing protocols that are used in younger and middle-aged adults should not be generalized to the older adult patient. Why is this relevant? It's relevant because age-related changes in the body impacts energy expenditure, impacts energy requirements, okay? The basal metabolic rate, or BMR, also termed the resting energy expenditure, is the principal determinant of total energy expenditure in the body. So a decrease in the BMR reflects a loss of lean body mass, including skeletal muscle mass. Energy expenditure related to physical activity is variable, and again, it is not the principal determinant of total energy expenditure. How do we estimate energy needs? An estimation of energy needs is based on body weight, and it's not solely based on lean body mass. So in determination of energy needs, care must be taken to avoid overfeeding while meeting basal requirements. What are the nutritional requirements of the older adult's body? The older adult's body has nutritional requirements that serve to sustain life. It also serves to maintain or promote good health. These nutritional requirements can be divided into 3 categories: macronutrients, micronutrients, and fluid needs. Nutritional requirements are often explained in terms of a balanced diet or a modified food guide pyramid. Age-related changes in physiology, age-related changes in metabolism, and age-related changes in function can alter or change the older adult's requirements, nutritional requirements, in such a way, again, that standardized nutrient requirements for younger or middle-aged individuals should not be generalized to the older adult. In terms of abnormal nutritional intake, the term is malnutrition. Over a prolonged period of time, it's malnutrition. Malnutrition in older adults ranges from undernutrition to overnutrition, okay? This is important because age-related changes in physiology and age-related changes in metabolism and age-related changes in function can change the older adult's nutritional requirements. And again, this leads to malnutrition. Potentially, it can lead to malnutrition. How do we measure nutritional status? The term anthropometric is used. An anthropometric relates to the study of the measurements of size and or proportions of the human body. Body mass index, or BMI, is a measurement of the body size, and it's an indirect measurement of body fat content. And this is often used to assess nutritional status in older adults. How do we calculate the BMI? The BMI is calculated by dividing the weight in kilograms by the height in meters squared. Okay? Normal BMI ranges between 18.5 to 25 kilograms per meter squared. Inadequate nutritional intake or undernutrition is characterized by a BMI of less than 17.5 or even 17. A BMI less than 17 is associated with an increased risk of diseases, and it's associated with an increased risk of mortality. Okay? In terms of prevalence of undernutrition, as much as 13% of outpatient older adults are undernourished. Undernutrition exists in as much as 25 to 50% of hospitalized older adults, and as much as 50% of skilled nursing facility residents have a diagnosis of undernutrition. What's the definition of undernutrition? Inadequate nutrient intake is an average intake of food groups, nutrients, or energy 25 to 50% below a threshold level of the recommended dietary intake. Again, an average intake of food groups, an average intake of nutrients, or an average intake of energy that is 25 to 50% below a threshold level of the recommended dietary intake. That is inadequate nutritional intake. And also, energy intake that's less than 50% of the basal metabolic requirements, that is associated with a higher risk of death, and it's associated with a higher risk of certain diseases. Lack of access to food frequently or commonly contributes to undernutrition. It is important to determine whether poor access to food, whether limitations in resources and limitations in transportation and limitations in functional status limits access to food. Poor intake is often an indication of illnesses. Unintended weight loss of 10 pounds or 5% of the usual body weight in a 6 to 12 month period is an indicator of underlying morbidity. Poor intake, which leads to unintended weight loss, is a predictor of functional decline. It's also a predictor of increased healthcare expenditure, and it's a predictor of an increased risk of hospitalization. Undernutrition and poor intake leads to unintended weight loss. It can also lead to micronutrient and or vitamin deficiencies, which is associated with cognitive impairment, decrease in memory. It's associated with a decrease in functional status. It's associated with an increased risk of infections, increased risk of pressure injury, pressure sores, and poor wound healing. And it's also associated with an increased risk of mortality or death. How do we address or how do we treat undernutrition? First and foremost, education is important. Preventive measures are important. So education and preventive measures. Goals of care should be aligned with the patient's wishes, what matters to the patient. If poor access to food is the underlying issue, provide access to food. Title 3C of the Older Americans Act, Nutrition Services Program, provides for congregate and home-delivered meals for older adults, irrespective of ability to pay, irrespective of economic status. The Older Adults Act emphasizes that adequate access to nutritious and appetizing food should be assured for patients of various cultural backgrounds and in all settings, again, irrespective of economic status. How do we address the issue of undernutrition? 1, provide access to food. 2, enhance food intake. Measures can be taken to enhance food intake by 1, catering to food preferences. Attention should be paid to consistency of food, the color of food, the taste, the temperature. Food should also be culturally sensitive. The setting in which food is provided is also very important. Eating together may increase sociability and the likelihood of an older adult actually consuming the food. How do we address undernutrition? Treat underlying medical problems. Provide appropriate mouth and hand care. If dentures, dental pain, gingivitis, if oral care is necessary, provide oral care. Avoid therapeutic diets unless clinical benefit is evidenced. Unless clinical benefit is evidence-based. Avoid therapeutic diets. There's evidence to show that increased caloric intake addresses undernutrition. So a balanced diet, yes. Nutritional supplements may be beneficial also. High caloric density, lactose-free, gluten-free nutritional supplements. There's evidence to support the fact that nutritional supplements correlate with small but consistent weight gain in older adults. It also correlates with a decrease in mortality in undernourished older adults. Caution must be taken. Caution that supplement does not replace and therefore decrease the overall intake of food and essential vitamins and minerals intake. In terms of medication management of undernutrition, there's no evidence-based report suggesting that long-term survival benefit exists with medication. Caution must be taken when using periactin and or megas. Appetite stimulants such as cyproheptadine or periactin causes confusion in older adults. Megestrol increases body fat content without significant clinical benefit, and megestrol or megas is also known to increase the risk of DVTs, deep venous thrombosis, and pulmonary embolism. It also increases the risk of fluid retention and congestive heart failure. Let's transition to obesity. A BMI of 30 kilograms per meter squared defines obesity. A BMI of 35 kilograms per meter squared is associated with an increased risk of functional decline among older adults. Poor diet quality and micronutrient deficiencies are relatively common in older adults, especially older adult women living alone. Excess body weight and modest weight gain in middle age may be associated with medical problems later on in life. So excess body weight and modest weight gain in middle age is associated with an increased risk of developing hypertension, diabetes, increased risk of developing heart disease and strokes, increased risk of developing sleep apnea, and increased risk of developing osteoarthritis later on in life. Excess body weight is also associated with an increased risk of impaired functional status, increased risk of utilization of healthcare resources, and an increased risk of mortality. How do we address obesity? How do we treat obesity? Education and encouragement is essential, and there's evidence to suggest that education and encouragement is more effective coming from a healthcare provider. In addressing obesity, care must be taken to reduce caloric intake. Okay, so a reduced calorie balanced diet is indicated. Regular physical activity also provides multiple significant health benefits for older adults. What is recommended? It's recommended to use moderate intensity aerobic physical activity or physical activity relative to ability. It's recommended to exercise 150 minutes per week, spread out throughout the week. That translates into approximately 30 minutes per day for at least 5 days per week. Muscle strengthening exercises, muscle strengthening physical activities at least 2 days a week is also shown to be beneficial. Thank you.